Very good morning. A very good morning to everyone. Uh, I know it's a little early in the morning, but still we have an interesting topic to discuss today. So I will be talking about childhood obesity in office practice. So the learning objectives for today's talk will be to outline the causes of childhood obesity, how to make a clinical diagnosis, screening, when to screen for complications, when to order for specific investigations, and when do we refer this child to a specialist. I'll also be discussing about the principles of managing obesity in a nutshell. So why do we need to worry so much about obesity? As we all know, obesity is a growing public health challenge. It's no longer a problem of the developed countries. It's making its way into low and middle income countries in the urban settings as well as in rural settings. It's been estimated from the WHO statistics that close to 39 million children under 5 years of age were overweight in 2020. The combined prevalence of overweight and obesity has almost tripled in the last decade. And almost 50% of these overweight children have lived in Asia. As we all know, these children are likely to stay obese into adulthood, and they're going to develop non-communicable diseases like diabetes or cardiovascular diseases at a much younger age than their older generations. But the silver lining to all this is that overweight and obesity, as well as the related diseases, are largely preventable. And prevention of childhood obesity, therefore, needs to be on the high priority list. So as we all know, obesity, the etiology of obesity can be broadly classified into lifestyle and diet related issues, which we commonly call as exogenous obesity, endocrine causes, genetic causes, which could be syndromic or it could be monogenic causes, and acquired causes. So exogenous obesity commonly results due to an imbalance between calorie excess and sedentary lifestyle. These are complex behavioral patterns that are seen, which can be seen in certain genetically predisposed individuals as well. So when the environmental factor adds to the genetically predisposed people, it can give rise to exogenous obesity. Endocrine obesity is commonly associated with underlying endocrine disorders such as hypothyroidism, Cushing syndrome, growth hormone deficiency, or pseudo-hypoparathyroidism. Syndromic causes such as Prader-Willi syndrome, Bardet-Biedl syndrome, they often are associated with abnormalities in the hypothalamus, in the neurohormonal regulation of appetite. They can have behavioral problems like hyperphagia. So they can be associated with obesity. Monogenic obesity refers to specific defects in genes involved in the energy balance and energy metabolism. And these are by far the rarer causes of obesity, but it's important to diagnose them because a lot of future therapeutics is targeted in these kinds of obesity. Acquired causes such as commonly used drugs such as antipsychotics, anticonvulsants, high-dose glucocorticoids, hypothalamic tumors or tumors of the pituitary hypothalamic area, surgeries involved in that area can disturb the appetite and satiety balance. And certain psychiatric and psychosocial issues can manifest as various types of eating disorders, which can also lead to obesity. So obesity as such is often looked at as a complex, multidimensional, the causes of obesity are often complex and multidimensional. There are individual factors within the child like intrauterine development, prenatal factors, ethnicity, genetics, the physical characteristics of the baby, dietary and sleeping patterns right from the early age. The socioeconomic factors that influence obesity are the individual and parent education, the household income and their access to healthy foods, their employment and their knowledge and practices regarding food and exercise. And as a community, the type of housing that they live in, the type of schools that they go, the literacy, the kind of access they have to play and the kind of access to food that they have, they all influence they in some or the other way, they will give rise to obesity. So whatever is the factor involved, ultimately the effector pathway is the pathways involved in the energy balance. As we all know, the hypothalamus is the main area which regulates the appetite. So there are two centers, the hunger center and the satiety center. So there are numerous signals. So the hunger signal is predominantly mediated by ghrelin, which is produced by the gastrointestinal or the stomach mucosa. The satiety signals are mediated by peptide YY, GLP-1, and pancreatic polypeptide. And adiposity signal, that is a signal of adequate energy, is mediated by insulin and leptin. So at any point of time, the relative balance between the hunger stimulating peptides and the satiety stimulating peptides is going to determine which of the neurohormonal signaling pathways are activated in the hypothalamus. So if the predominant stimulation is to the hunger pathway, then the individual tends to eat more food and consume less energy. Whereas if the predominant stimulation is towards the satiety pathway, the opposite happens. So there could be various factors here. There could be defects in any of these hormones. There could be behavioral problems such as sleep and psychiatric conditions, which can affect the rhythm of biological rhythm of these peptides and hormones, and ultimately affect the pathways, giving rise to obesity. So what are the functional aspects of a child being obese? So we often call it as the vicious cycle of obesity. So usually a healthy child, due to whatever reason, okay, most common cause being exogenous obesity. So an imbalance with an excess calorie with a sedentary lifestyle is going to lead to a mildly obese child. So the mildly obese child is less likely to be active than his healthy counterpart. And this child will continue to eat the same amount of food that he used to do. So this will give rise to a moderately obese child. So it becomes more and more difficult for the moderately obese child to exercise, and it becomes more uncomfortable and painful. So as the child becomes more obese, a lot of things get added, other comorbidities, and such as asthma, diabetes, or even musculoskeletal issues. They can prevent the child, even low self-esteem and other aspects. They make it more and more difficult for this child to exercise, and this child can still be continuing consuming the same amount of calories, or this child can also lead to stress eating and other forms of disordered eating, which will ultimately give rise to a severely obese child. A severely obese child, if unattended, is going to become a severely obese adult. So at some point, we have to break this cycle. So how do we go about that? So most of the time, a general pediatrician or a general practitioner will not see an obese child just like that. Usually, the mindset is that an obese child is equated to be a healthy child. It's only when there are some consequences of obesity that is the time the child usually is brought to the doctor or the physician. So what are the main health consequences of obesity? So it could be endocrine or immune response, affecting the glucose tolerance, the spectrum of which could be impaired tolerance to frank type 2 diabetes mellitus, insulin resistance, metabolic syndrome, hypertension, dyslipidemia, menstrual dysfunction due to polycystic ovarian syndrome. This is often seen in adolescent obese girls. Early puberty can be a sign in younger girls, delayed puberty in adolescent boys, gynecomastia. They can be brought with issues related to or symptoms related to non-alcoholic fatty liver disease or cholecystitis. So the other clinical manifestations could be because of the physical response to obesity. This could be in the form of lipomastia. Tissue compression could lead to symptoms of sleep apnea and gastroesophageal reflux. Tissue friction could lead to intertrigo. Stress on weight-bearing joints could lead to bowing of knees, hip pains, and slip capital femoral epiphysis. The other more hidden symptoms could be the psychological response. These children can be brought to a psychologist or a psychiatric clinic with complaints of anxiety or depression due to isolation from peers, bullying, or due to disordered eating. So these could be the different reasons why an obese child could be brought to the clinic. So it's important that when we evaluate, we take a detailed history to include the nutritional history, appetite, the level of physical activity, not only of the child, but also of the whole family or the immediate or extended family that the child resides with or stays with, comorbidities and symptoms of underlying disease. Physical examination with emphasis on blood pressure monitoring, a focused review of systems, weight assessment with BMI, waist circumference, and linear growth assessment. So every child who comes to us should have the child's weight, height, and body mass index recorded on a growth chart. So the diagnosis of obesity is made mainly on the body mass index. So a child more than 2 years of age is diagnosed to be obese when the BMI is more than the 85th but less than the 95th percentile in the age-specific age and sex-specific growth chart. Overweight is a child, obese is a child whose weight or whose BMI is more than the 95th percentile, and extreme obesity is defined as BMI more than 120% of the 95th percentile, or an absolute value of 35 kg per meter square, whichever is the lower value. As we all know, body mass index is calculated by dividing the weight in kg and the height in square meters. In a child less than 2 years of age, BMI charts are not validated. So we use the weight for length, weight for recumbent length chart, weight for length chart. So a child less than 2 years of age with a weight for length more than 97.7 percentile is also diagnosed to have obesity. So it's important to use the percentiles of BMI and not the absolute BMIs which we use in adults. This is because BMI in children is a dynamic thing. It keeps changing with age. We'll talk about it more in my next slide. So a child with a BMI of 23, a 10-year-old child, is obese, but the same child, if he's a 15-year-old and with the same BMI, it will be in the normal range. So that's why it's important to use the age-specific BMI charts to make a diagnosis of obesity in children. So another concept which we need to understand is adiposity rebound. As we can see, this is a normal BMI percentile chart. So physiologically, the BMI increases during the first 2 years of life, and then it gradually declines and reaches its low point somewhere around 4 to 6, or around 6 to 8 years of age. So this is, and after this, the BMI gradually increases with age, and then it increases as the child enters the pubertal growth spurt. So this point at which the BMI starts to increase again is called as adiposity rebound. So adiposity rebound is a normal physiological pattern that is seen in all children, but the age at which the adiposity rebound happens, as you can see here, as the weight or the BMI increases, the adiposity rebound happens at a much earlier age. So studies have shown that early adiposity rebound, which is less than 4 years of age, is a predictor for adult obesity. And this age, the age before which adiposity rebound occurs, that is a potential time frame for us as physicians to intervene and to implement preventive strategies. So coming to physical examination, we have to perform a targeted review of systems. Apart from the anthropometry, pulse, respiration, and blood pressure monitoring should be given special emphasis. So any child who comes to us, the child might just be brought with a concern of being overweight or obese. So all overweight children who come to us should be screened for these symptoms, especially depressive symptoms with a history of anxiety or school avoidance, polyuria, polydipsia, and weight loss for type 2 diabetes, frequent morning headaches for pseudotumor cerebri, sleep disordered breathing, which could manifest as night breathing difficulties, excessive snoring, daytime sleepiness. It could indicate an underlying hypoventilation syndrome because of the excess body fat. Recurrent unexplained abdominal pain could be due to GER, gallbladder disease, or constipation. Hip or knee pains, these should be specifically asked for and looked for. So some of the signs that we need to pay attention are any child who's presenting with poor linear growth, look for underlying signs of hypothyroidism, Cushing's, or Prader-Willi syndrome. Dysmorphic features, usually in the setting of developmental delay. In a younger child, less than 5 years of age, should always prompt to think in lines of a genetic form of obesity. Acanthosis nigricans, hirsutism could be the common clinical manifestations of nutritional obesity. We also need to look for any abdominal tenderness, hepatomegaly, and limited hip range of motion. So this may not be apparent, but it needs to be looked for in every obese child that comes to our OPD. So some of the clinical pointers for a nutritional or exogenous cause is the history points towards a calorie excess with a sedentary lifestyle. They may not have symptoms of an underlying disease, but they can have symptoms of comorbidities. The linear growth is almost always normal, or it can be accelerated for age, which is usually depicted in the form of an advanced bone age. They can have acanthosis nigricans, which is a sign of insulin resistance. And some of these children can be brought to us with premature thelarche, pubarche, or even gynecomastia. So pointers towards endocrine cause are a decreased or a decelerating linear growth. They usually have a disproportionate short stature. They can have typical facial skeletal features, truncal obesity of an underlying endocrine disorder. To illustrate, so this is a child with exogenous Cushing syndrome who happen to have increased weight gain, the characteristic facial features with excessive cheek pad of fat. So this is a pointer towards Cushing syndrome. So this is a child with pseudo hypoparathyroidism. So usually these children are short and they are obese. The obesity is predominantly truncal, but they can have stigmata, or they can have markers of the underlying disease. This is typically skeletal manifestations of PHP with short foot metacarpals, which are seen on clinical examination. This is a classic child with congenital growth hormone deficiency, where you can have the characteristic facial features, the truncal obesity, a disproportionate short stature, and also this child seems to have micropenis. So these are the clinical pointers that need to be looked for if we are suspecting an endocrine cause for obesity. The other rarer entity is a genetic obesity. Genetic obesity should be suspected in any severe early onset obesity in a child less than 5 years of age. These children may have dysmorphic features, may or may not be associated with hyperphagia. They may have developmental delay, and they often have a positive family history, especially in children with monogenic obesities. So any of these children should be evaluated thoroughly to look for any intellectual abnormalities. Associated endocrine abnormalities such as hypogonadism or hypothyroidism can be seen in leptin deficiency and leptin receptor mutations. Pro-opiomelanocortin, which is an important signal path, it plays a very important role in the signaling pathway in the hypothalamus. It can be associated with ACTH deficiency and light-colored or ginger-colored hair. So when these clinical pointers are there, it's important that these children are referred to a specialist early on so that a genetic diagnosis can be made, and they can be followed up. They can be put on surveillance for the other spectrum of complications that they can have. So this is a picture of an infant with leptin receptor resistance. So usually they present with severe early onset obesity after birth, less than 6 months of age. So this is a typical child with Prader-Willi syndrome who has hyperphagia associated obesity. The obesity is, they have typical clinical features, and in these syndromes, obesity is usually seen after the 2nd to 3rd year of age when the hyperphagia kicks in. So coming to investigations. So screening for comorbidities has to be done in all overweight and obese children more than 3 years of age. So this is universal irrespective of the cause of obesity. So whenever we have a child with obesity with low growth velocity, associated symptoms or comorbidities, an endocrine evaluation needs to be carried out. The common screening tests that we use are a bone age X-ray to look for the skeletal maturation, a TSH, free T4, IGF-1, and 8 AM cortisol levels. So another common entity that we often see in our OPD is an elevated TSH in a child with obesity. So even nutritional causes or exogenous cause of obesity is associated with mild hyperthyroidropenia or mildly elevated TSH levels. So this seems to be an adaptive response to the increased calorie intake and subsequent metabolic pathways that get activated because of that. So in these children, the elevated TSH is more of a result of the obesity and not the cause of the obesity. So often we have children who are brought to us and with exogenous cause of obesity, and the parents just want to label, they just want to find a reason for that. So they think that thyroid is the cause for that. So that is not true, and they have to be educated that it is the other way around. It's the obesity which is causing the elevated TSH, and such elevated TSH levels need not be treated with thyroxine uh, unless they have symptoms of hypothyroidism, and these children will show a reduction in TSH levels as they lose weight. So genetic testing is recommended for early onset severe obesity, especially when they have clinical markers and there is a positive family history. Some of the genetic tests that we do are karyotype and methylation studies for Prader-Willi syndrome, and whole exome sequencing, next generation sequencing may have to be done for other suspected genetic disorders. So screening for comorbidities. So this is recommended by the Pediatric Task Force on Obesity Assessment, Treatment and Prevention by Endocrine Society in 2017. So they have provided consensus guidelines on the management. So the screening has to be done for impaired glucose tolerance, for dyslipidemia, hypertension, for non-alcoholic fatty liver disease, for sleep apnea, for obstructive sleep apnea, and for any psychiatric symptoms. So for pre-diabetes, for impaired glucose tolerance, we do an HbA1c or a fasting blood glucose to diagnose pre-diabetes. And if you're frankly suspecting diabetes, then the child may also have to undergo an oral glucose tolerance test, especially in children more than 10 years of age. So dyslipidemia, fasting lipids is recommended. Various cutoffs are provided. So triglycerides in less than 10-year-olds, the cutoff should be less than 100, and LDL cholesterol, it should be less than 130. So any values which are more than the cutoffs will have to be managed as per the specific protocol for management of dyslipidemia. So pre-hypertension and hypertension is one of the other important comorbidities. So all children above 3 years of age must have their blood pressure checked at a routine OP visit. So a blood pressure between 90th to 95th percentile is regarded as pre-hypertension, and anything more than 95th percentile is hypertension. So appropriate pharmacological or non-pharmacological interventions will have to be made based on the blood pressure. So non-alcoholic fatty liver disease is diagnosed when an SGPT is more than 25 units in boys and 22 units in girls. So this can give rise to various symptoms like abdominal pain, fatty liver, and it can lead to gallstones and symptoms related to that. PCOS should be suspected, especially in adolescent girls with obesity who present with irregular menstrual cycles or menstrual dysfunction. So they can be screened with free and total testosterone levels. All children who come to us should be screened, preferably with a questionnaire for symptoms of obstructive sleep apnea or for symptoms of an underlying psychiatric disorder. And if there is a positive history, they have to be promptly referred to the appropriate specialist. Coming to management. So the management of obesity always we have to remember that it has to be a family-centric approach. So this is the cornerstone of a successful obesity management. So it has been shown that in children with whom the family is actively involved in their obesity management tend to have a greater loss in BMI, a better quality of life as compared to those families where the family is not involved. So the family-centric approach should involve all aspects of obesity management, not just oral intake, but also physical activity, behavior, as well as pharmacological. So intake is mainly focusing on the preventive aspects. So we need to emphasize them about regular timely meals, not to skip breakfast, encourage breastfeeding in younger children, reduce the frequency of eating out, reduce sweetened and packaged food, encourage consumption of whole foods, to have a no TV during meals policy. The family should eat together as often as possible, and they need to be educated regarding portion control. Physical activity should be recommended at all ages, starting from the toddler age group. So less than 5 years, they should be encouraged in active playing as far as possible. More than 5 years, 20 to 60 minutes of moderate to vigorous physical activity at least 5 days a week has to be encouraged. So as we saw the energy balance pathway, sleep-wake cycles play a very important role in the hormonal regulation. So any changes in the sleep-wake cycle, any underlying psychiatric disorder, this can affect the biological rhythm of the various neurotransmitters that are involved in the energy balance pathway, and this can lead to a dysregulated appetite. So emphasizing on adequate sleep, age-appropriate sleep duration has to be done. We need to encourage healthy interfamily communication and stress a lot on the parents adopting most of these to act as role models, because children emulate the patterns that the parents follow. So that if the children notice a healthy pattern or healthy role model in the parent from a younger age, they're less likely to be obese later on. So pharmacological management is restricted to a small group where there is failure of lifestyle interventions or associated with severe comorbidities. Orlistat and metformin are some of the drugs that have been tried. Specific treatment in genetic obesity, for example, octreotide and leptin deficiency can be treated with leptin analogs, and growth hormone in syndromes such as Prader-Willi syndrome. They also have they also have a modulatory role in which they help to improve the appetite and the body composition. Bariatric surgery is reserved for morbid obesity. So in OPD practice, what we can do is at every visit, even though the child is not yet obese, or if we find a child who's having an early adiposity rebound, so we employ the prevention plus, where we encourage them, we educate them about decreasing consumption of fast foods, avoiding high fat, high sodium and processed food, educate them about portion control, recognize eating cues. A lot of time children might just eat because of boredom, loneliness, excessive stress or screen time. So parents should be taught how to look out for these cues, and we can make it interesting for the child as well, make the child a part of the conversation. So provide audiovisual aids like the My Kids Plate, where you encourage the child to incorporate a healthy diet, what vegetables to choose, fruits and grains, protein and dairy, and the child can be made to customize what they want to eat and what they don't want to eat. So this could be one of the ways to give them a structured diet and meal program. So prevention is always better than cure. So in less than 2 years of age, we should always promote exclusive breastfeeding till 6 months of age and continue breastfeeding till 2 years of age. So avoid exposing the younger child to sweetened beverages, introduce a variety of healthy foods, and avoid restrictive diets. And as far as possible, avoid screen time in children less than 2 years of age. In 2 to 12 years of age, we need to promote education and food knowledge. We can use AVQs. We can encourage the child by taking them out for grocery shopping or taking them out to the farms, teaching them what healthy foods are, give a positive outlook about healthy foods. So children at this stage should be encouraged to take at least 5 portions of fruits and veggies, and they should have scheduled meals like 3 meals and 2 minor snacks. And they should be encouraged to take part in various forms of physical activity. So an older child, more than an older adolescent, can be, we can help them to adopt a healthy lifestyle by involving them in meal planning and preparing, and also allowing them to choose a healthy snack on their own. So children at this stage have a lot of, they want a lot of autonomy. So they don't want to be told what to eat, and restrictive diets might often encourage them to do more of that. So it's better to give them the choice and to choose healthy snacks, and that way promote a healthy communication and bonding in them. So some of the activities that can be recommended are running and jumping, which are aerobic exercises, bone building exercises such as hopping and jumping, muscle strengthening such as push-ups, tree climbing, sit-ups. And older children can be either enrolled for competitive sports like soccer or baseball in other countries, or any other sport that they are interested in. What is important is it should be something which the child enjoys, preferably the parent also enjoys. So it will be a family bonding time as well as a healthy activity. And free play should be encouraged, such as walking, dancing, or any other activity which is possible for the family to do. So the American Academy of Pediatrics promotes active, healthy living and suggests the following exercise programs. So younger children, they usually enjoy, toddlers enjoy outdoor physical activity. So they should be allowed for unstructured exploration, like just walking in the neighborhood, preferably with a parent or a grandparent, okay, walking outdoors. So preschool children, 4 to 6 years of age, they should be encouraged for running, swimming, tumbling, throwing, and catching activities. They should be allowed to walk tolerable distances with the family. And as far as possible, reduce sedentary transportation with automobiles or even strollers. So older children can be encouraged to take part in any physical activity that they enjoy in. It could either be organized and structured, competitive sports, or it could be just play. So enjoy it. What is important is that these activities are carried out intermittently, frequently, at least for 40 to 60 minutes, at least 5 days a week, five on most days, but at least 5 days a week. So is multifactorial. It has to be family centric, healthy eating and family centric, physical activity, and reduced screen time. So, with this, I would like to end my talk. So, the take home message would be always prevention is better than cure. So, as pediatricians, what we can do is start plotting the BMI on charts so that we can do early tracking of the adiposity rebound and start preventive education right from the first visit so that it is reinforced every time the child comes to us for any other reason, like a routine immunization or any other illness, so that we can track the adiposity early on and we can prevent the progression of obesity. So some of the red flags to look for us in children who come to us with early onset severe obesity, developmental delay, or dysmorphism, these children need to be referred to an appropriate specialist, or any child with obesity who has short stature, growth deceleration has to be referred to an endocrinologist. All children who come to us who are more than 3 years of age who are overweight and obese should be screened for comorbidities. So promoting healthy eating and physical activity at the very first visit. So it has to be a family-centric, culturally appropriate and age-appropriate advice that we need to give. So if lifestyle measures fail or if there are associated comorbidities, they may not they have to be referred to specialists for further management. So these are my resources. There are a lot of guidelines and articles available, which can give us an idea as to how to approach obesity in children. Thank you for your patient listening. Are there any questions?
Thanks, Dr. Namratha. Thank you so much. I was just wondering, the
Yes.
regrading, for example, you have made a diagnosis of obesity, okay,
Yes.
and then you are instituting some changes, so the
Yeah.
nutrition or the exercise and things like that. So
Yeah.
how do you suggest that to the families? Who does it? And then
Yeah.
what is the right way of targeting the weight or the BMI?
Yes. Yes. Yeah. I had not included that. So once we initiate any of these lifestyle measures, preventive as well as lifestyle measures, we usually review the child. We ask them to review in 3 to 6 months. So the target would be in overweight children, it would be to maintain the same weight or to bring down the BMI to less than the 85th percentile. So this will be our endpoint, which we will be monitoring. And in children who are already obese, like more than 90th percentile, so the aim is to obtain steady weight loss. So we don't want rapid weight loss because this is the lifestyle measure which we are introducing. So about 5 to 10% weight loss in the first 6 months to 1 year is what we target at. So this can be this progress can be shown to them on the growth chart. So it's often reassuring, or it's a positive reinforcement for them when they see that the BMI centile is coming down. And this can be done by general practitioners or general pediatricians. And if there are any comorbidities, then they can be referred to a specialist. And if these measures fail, like in 3 to 6 months of age, it has not been effective, we need to enroll this child into a structured weight management program, where we will have to give a formal dietary prescription and a formal physical activity regimen for this child. And this child might have to have frequent visits, probably every 4 to 8 weeks, might have to meet the specialist to track their progress. And any other issue, any other thing that is not allowing them, especially family issues, psychological or psychiatric issues, any other issue which is coming in the way, it needs to be screened for and addressed appropriately.
So do you have the systems in place in RV for doing all this?
Yes. Yes, so any child who's referred to us, we do a comprehensive evaluation. We will give them, we will screen them for comorbidities, and we will give them a plan, including diet and physical activity regimen. And we will also advise them what their target should be. And we follow them up. We encourage them to come back to us.
Thank you so much. Anyone else with any questions? Thank you so much, Dr. Namratha.
Okay. Thank you, everyone, for your patient listening. Thank you, Dr. Sujata.
Thank you, Dr. Namratha. Great talk.
Thank you.